Great. Thank you very much. I'm Roger Glass. I'm the director of the Fogarty International Center at NIH and the associate director for global health at NIH. So I work with all the 27 institutes and centers at NIH on their global health agenda. And I must say, in the directorship of Dr. Francis Collins, he's encouraged each of the institutes to engage in global health. NIH also sponsors the National Library of Medicine, which provides to the world's community as a global public good access to PubMed, to the GenBank genetics banks, and to clinicaltrials.gov, so that all of that information is available to the global community. I want to give you a few ideas in response to your questions, as well as some background on what we do. And I would say that on your first question of internal versus external focus, NIH will fund the best and the most outstanding research anywhere in the world. Anywhere in the world. And with that, it has to come through our peer review system. In many places, we go where there are opportunities of unusual exposures, risks, are unique opportunities. And consequently, we have and fund research in over 100 countries. It's all available on Reporter. So as a beginning, we do fund internationally, and it is a priority if it goes through peer review. We work on both fundamental research, extending our knowledge of human health and disease, as well as the application of that knowledge in the field to extend healthy life. Well, Americans have benefited greatly from the results of global health research. Mike Merson and I were involved in oral rehydration therapy years ago in Bangladesh for cholera, and that's become the treatment of choice in the United States for the treatment of diarrheal disease in children. And it's a big business in this country that developed from small investments in health. But you can see on the list in gene discovery, the identification of new diseases like Burkitt's lymphoma, the use of antimitotics in Uganda. These are all areas where the U.S. public has benefited from investigation done globally and supported by NIH. So we've gained a lot from our global investments. At the same time, we look back, and when I first came to Fogarty 10 years ago, we saw that so much had changed from the 1997 report to the 2007 that we thought that a new report was warranted. We're in the same position now, and I think that report was very helpful. We're in the same position now, and a lot has happened in the past 8 years since that report. Advances in science, the science of genomics, proteomics, nanoscience, molecular biology, CRISPR-Cas, the advances are astounding, and it puts before us opportunities for research advances that we've never anticipated and couldn't have anticipated 8 years ago. As Ray Kurzweil said, the speed of biomedical advance is accelerating like Moore's law. And research, because of this research, we have new aspirational goals. We've moved the goalpost of where we would like to be. The end of AIDS in a generation, improvements in maternal and child mortality, addressing mental illness and the NCDs. We've done this by the launch of a number of major programs at NIH, the Precision Medicine Initiative to develop global cohorts, the million-person cohort that's just beginning, a brain initiative, big data, the cancer moonshot that was announced by Vice President Biden, the global health security agenda. So we really have only been able to consider these advances in programs because of the research agenda that's gone before. So all of these agendas have a global dimension, and I think that's key to our thinking about the future. Well, in the 21st century, we've really moved on. Global health is clearly in transition. We have the unfinished agenda of infectious disease and emerging pathogens, the NCD agenda, which has been hearkened at the UN General Assembly and is quite common, and new problems of hazards, injuries, accidents, and the like. We are well prepared to have people in place to think about the infectious disease and HIV. We've trained researchers. For the NCDs, for cardiovascular, global cardiology, global diabetes, global mental illness, we really don't have a workforce in the United States capable of conducting research in these areas. That would be one of the priorities I would put before the committee as we go forward. And finally, there are lots of new problems that are occurring on addictions, accidents, and the like, and those we need to train for those. You know, Wayne Gretzky said, you can't go for the puck, you have to go for where the puck will be. And I think in this case, it's got to be in 4 or 8 years hence, where we need to be and what we need to train for, because research takes time. Well, over the last 8 years and before, we've had a number of major presidential initiatives. PEPFAR, the President's Malaria Initiative, the Global Health Security Activity, neglected tropical diseases. All of these will require research, new research, to sustain the gains that have been achieved. If we can figure out ways to deliver antiretroviral drugs on a quarterly basis instead of a daily basis, we will change the game. If we develop new ways to address or vaccines for malaria, we will change the game. And if we can make these investments and see them through to their conclusion, we'll have done amazing things. That will change the game. Well, let's think about how we can do this as we go forward. And I think your second is what our priorities should be. Partnerships are one way that we can extend what we do in global health research. And I want to give you 2 examples. For one, Dr. Collins is now the lead of a group that's called the Heads of International Research Organizations, a dozen international funders who fund 90% of the research in the world. And with this group, there's great consideration and collaboration on what are the problems before us today. Issues like the ethics of stem cell research, CRISPR-Cas, fraudulent data, all sorts of questions that we share with common research funders. But also this Global Alliance for Chronic Diseases, a group of about 12 research funders around the world that are trying to address the common global agendas for the NCDs, the Global Alliance for Chronic Diseases. They've taken up now 3 agendas: hypertension, diabetes, and environmental lung disease, the current call. Mental health will be the next call. And this group together has invested over $100 million in partnerships. We're working, and in the future, we would like to see common global calls on issues of major importance to the world and ways that we can scale up the research that we know that works. And I think this partnership will be critical to our success in the future. Another example of global collaboration around the world, high-income countries and low-income countries, is the Cancer Genome Atlas, an attempt by NIH and the NCI to map about 20 cancer types in detail, because we see cancer in part as a genetic disease. And if we can go where the cancers are and let countries participate in sequencing the cancers of priority in their countries, we can perhaps identify new targets for cancer research, drug therapy, improvements, and cure. And so this is an ongoing endeavor that will be part of the cancer moonshot as we move ahead. So global partnerships here are essential to accelerate discovery. We can't do it alone, but with partnerships, we can do a lot. Alzheimer's. If I look around this room, 1/3 of you, when you get to be 70, are going to start having Alzheimer's. This is going to bankrupt our budget for health. Where can we look for new solutions for Alzheimer's? It's going to be in the global health arena as well. Groups like this in Colombia that have identified cohorts of Colombian individuals, descendants of a single woman who came from Europe with specific genes, and from these patients and these families, we can identify biomarkers for Alzheimer's, and we can bring these people for treatment because they have a high prevalence of disease that's rapidly progressive. These studies are ongoing and will be critical to the health of all of us in this room, global health research. We also have, through Fogarty, invested in leaders. Almost 30 years ago, we invested in leaders to learn about HIV research when HIV was not a global health problem. These students of 20, 30 years ago, of the past 2 or 3 decades, have grown up to be leaders in health research in their country. And they are part of our global effort to control HIV. They've conducted trials that have led to new discoveries. They're independent researchers, and they've changed the way we think about this disease. We could not have accomplished what we have without the extended network of foreign investigators who have the populations and the resources to make a difference in their research. This has been huge. We're also thinking about the next generation of global health researchers. I mentioned that we have lots of researchers who have experience in infectious disease and HIV. We have precious few who have worked on global cardiology, global cancer, global diabetes, global mental health, global addiction, and the like. And so here we have a program where we send about 100 people a year for mentored research training to begin their careers and come back and get grants and support research in global health, sharing our experience. We need to train the research workforce of tomorrow today. We've also engaged in this MEPI program, the Medical Education Partnership Initiative, because we see the importance of extending the reach of our research into Africa for many problems and to develop their independence. We've used this network of 13 grantees to enhance their curriculum, to build South-South collaborations, to put research into the medical schools so they can begin researching problems that are important to their own countries and let them decide, to improve faculty recruitment and retention, and to influence national policy. So this program that's now being reinstated for the next 5 years has really changed the way we think about global health in Africa and the opportunities for discovery. This group that had never met before 5 years ago came together at the end of this grant to form an African Forum for Research and Education in Health, trying to unify the 160 or so schools of medicine and allied health sciences in Africa into a unit that can benefit from the network that's been developed. This small grant has been able to bring together, will be able in the future to bring together most of the medical schools in Africa and to gear many of them on a research agenda. I just returned from a visit to the MEPI group and other sites in Africa with Francis Collins. And here we were in Eldoret, Kenya, with Dr. Joe Mamlin, who began a partnership 25 years ago with Moy University. He was the chief of medicine in Indiana. He brought in a dozen partners, including Mount Sinai, Valentine, and I met your cardiologist there. I went to visit the cardiac clinic there. And this clinic, you can see Dr. Lawrence in the back from Duke, a Duke professor. And you see him there with 8 fellows learning in cardiology in a beautiful facility that you would never believe was in rural Africa, Eldoret. How did this group get there? They got there because a fellow in cardiology from Duke, Jerry Bloomfield, went out as a Fogarty fellow 7 years ago, came back and got a K award from NIH-Uganda, sent his junior fellows out to Eldoret to work on the same research project, got a Duke donor to contribute the cardiac center that's part of a network that reaches out to 1 million people, and now has professors from Duke going out there on rotation. Began as a single fellow 7 years ago, and we have fellows from other schools like Mount Sinai in this facility. We went to Uganda to meet with Peter Mugenye. Peter was trained as a researcher, introduced the first use of antiretrovirals in Uganda. He advanced through different research projects over the years. He's the second largest provider of HIV therapy in Uganda and in Africa. Provided services, advised President Bush on PEPFAR, has really built the economy of the area through employment of people and prevention of death and morbidity from HIV, and has changed health policies in the country. He's really securing the future, and he's an incredible health diplomat, if you will, for NIH grantees and research. We went to the Zika forest with Dr. Collins right near the Entebbe airport in Uganda. Why was Zika discovered in Uganda, and how does that have relevance for us today? Well, this was started by investments of Rockefeller about 60 years ago to look for viruses in Africa. And it was because of that investment of Rockefeller that when a Marburg outbreak occurred at the time of the Ebola outbreak, no one heard about it because the Ugandans knew exactly what to do and had the laboratory and epidemiologic resources to control that infection. There's a capacity training that's absolutely essential to ensure global health security. We met yesterday with this man, Dr. Eliota, the Minister of Science, Technology, and Innovation in Uganda, with Francis Collins. The government of Uganda signed, they're so interested in research that they signed an agreement that any NIH grant that goes to a Ugandan investigator will be added onto by a grant from the government of Uganda for additional postdocs and for administrative costs for the grant. The Ugandans want to invest more in research on their own, and they want to direct their own research. And here we have demonstration. Dr. Eliota was a NIH grantee and a Fogarty Fellow who rose to become Minister of Health and had so many innovative ideas that they made him the Minister of Science, Technology, and Innovation. Investing in people early and research has made a huge difference in that setting. Finally, I want to just end with Zika, because if we look at our portfolio of grants, we see that these three countries were plagued by the Ebola outbreak. Why were they plagued, and why were there not outbreaks in Senegal, Mali, Nigeria, Ghana, and Nigeria, where cases were at the front door? The difference was that those other countries had either PEPFAR investments, NIH grants, capacity building, network to U.S. investigators that allowed them to do the right things in contact tracing to stop the epidemic. In these countries where we have precious little investment, they were left abandoned. And I think as we think about what we can do for U.S. government interactions, here, while we had a wonderful response and rapid response to this outbreak, what we need to do is build the capacity in those countries so that we have the people capable of responding to the next outbreak. Future preparedness. So the needs for the future, one would be for us research training. Prepare the biomedical research workforce for tomorrow, both at home and abroad, because we do not have researchers capable of thinking about global health research in areas outside of the obvious things of infectious disease and HIV. The NCD agenda, we really need people supported there. We have huge enthusiasm for global health on campuses around the United States, but we don't have adequate funding to support those universities to train people adequately and to seek global health opportunities. We want to ensure that U.S. universities and research centers maintain their preeminence in medical research and continue to train the best and the brightest from home and abroad. And we want to really train that next generation of scientific leaders and researchers in low and middle income countries, but also to benefit researchers anywhere in the world who have good ideas or unique opportunities, unusual exposures, or unusual risk factors that they address. We want to catalyze partnerships, leverage governments, private and donor investments to ensure sustainable, long-term, productive research relationships. We need to create centers of excellence where they don't exist and provide training in global health that attracts research funding so that these groups can become independent over time, and build that IT infrastructure that's so essential to promote South-South and North-South networks, collaboration, long-distance learning, and research. So I want to just end by why we invest in global health. It's really the new frontier of science, especially for the NCDs and the other areas of biomedical research. It's good for diplomacy, good for humanity, good for business and competition, good for our own future. Just to end on your three questions, Agenda, on internal or external, I think I've said that we will fund the best and most outstanding research that meets peer review, or that either occurs in an area which has unusual exposures, like the Zika outbreak now in Brazil, unusual environmental exposures or genetic cohorts. And we have cohorts in places like Pakistan with congenital hearing loss where we've discovered the genes of hearing through this inbred population. We want to better improve the responsiveness of the government. We've seen with the Ebola that there's a lot of money for the immediate response. When it comes for a response next year, unless we have in place people capable of responding to the outbreak, laboratories capable, that research component, people, manpower capable of doing research, we won't be able to stop the next outbreak. And for priorities, I want to give you my 4 Ps. The first is recognizing the value of research, because I think I'm the only person on the panel who's going to speak specifically to research. I think the research budget is the first part to get cut out or not considered. We've had tremendous support for research from Congress, but for the global health agenda, we could use even more because we see new opportunities. The second is partnerships, and I think those partnerships are essential. Partnerships, as I mentioned, with the HEROES and the GACD groups, partnerships with industry, so we can think about point-of-care diagnostics and new events, new drug discovery, all kinds of partnerships that will help us advance the research agenda. The third P is people, and I mentioned both U.S. and foreign investigators in whom we need to invest with research training, and priorities. And I think our 2 sets of priorities, one are to go where technology takes us, because with the new advances in genomics, in imaging and CRISPR-Cas and the like, we have opportunities that we've never had before in science, and go where the disease priorities take us, again, and what are the priorities for us here at home, but internationally. Thank you very much, and I welcome the opportunity to respond to the committee.